We are live.
A very good evening to one and all. Today we are starting with our new module, this refractive module, and this is the first class of this module. This is lecture 450 of the iFocus online. Dr. Navneet Sidhu, who will be teaching us Corneal optical principles. Welcome, Dr. Navneet. Um, for our session's moderator today, we have Major. Sir has done his MBBS from Maulana Azad Medical College and of Thal from done his fellowship from Aravind, and he has done fellowship in cornea and microsurgery at Aravind Madurai. Sir holds an ICO fellowship from Michigan. He's also worked as he was a associate consultant time at Center. Sir has started his own, which is Dudeja Eye and ENT Surgery, Eye and ENT Care Center, Sonipat. He's a surgeon par excellence. Welcome, sir. And over to you, sir, for the introduction of our chairperson today and our speaker for the day.
Thank you, Dr. Kanika. Can you change the slide? Yeah. So we have Dr. Uma Sridhar, who will be chairing today's session. She has done MS, DNB, FRCS, Edinburgh Royal College of Surgeons, and fellowship from LV Prasad Institute in cornea and anterior segment. She worked as a consultant cornea and anterior segment at Eye Care Eye Hospital and Postgraduate Institute, Noida, from February 2002 to 2005, and she has been a DNB coordinator and nodal officer, more than 7,000 FACOs, 2,000 ECCs, so surgeon par excellence, and lot of surgical experience. She has mentored as a guide in 17 theses and contributed in so many chapters in more than 15 chapters in various books. Welcome, Uma ma'am, for chair and accepting our offer as a chairperson. Thank you, ma'am.
Thank you, Dr. Akshay.
Next slide, please. So I request Dr. Navneet, ma'am, to start today's session. Can I have Dr. Navneet ma'am's introduction as well? Kanika? So Dr. Navneet is working as an associate consultant at Center for Sight. She has multiple publications in her name and an very esteemed surgeon at Center for Sight. I invite you, ma'am, for today's class.
Thank you, sir.
Yes.
So, I'm unable to share my screen.
Yeah, please do so, doctor.
Yeah. So, is my screen visible now?
No, not yet, ma'am, not yet.
Ma'am, are you on a Zoom window?
Yes, I am
Just
on
click
the
on the
Zoom.
green button bottom which says share,
Yeah.
and then the blue button when the pop-up comes. That's it.
So, I'm selecting Microsoft PowerPoint.
Don't select anything, doctor. Just select the entire screen.
Okay.
The green button and simply the blue button.
Okay.
Nothing is visible, doctor.
I'm selecting it. Is it visible now?
Dr. Sidhu, you're on Mac.
Yes.
You need to give permission first. I believe your system will require
Okay.
permissions.
Okay. So how do I do that?
Uh, have you tried? I mean, are you getting a pop-up?
No, there's no pop-up.
Uh,
Okay.
can we go to system preferences? Settings, basically zip settings में.
Okay.
And hello, am I audible?
Hi. I can hear you.
Just a sec.
It's sending video is selected.
Oh, just a sec. Just open the privacy and security.
Okay.
Under privacy, when you scroll down, you will have permission for Zoom.
In
Are
the
you
security.
have you joined through browser?
Yes.
No, you need to log off and join through application, please.
Okay.
Just
Okay.
log off and
Just
please join. Don't join through browser. Join through application. We are
okay.
holding.
Okay.
We are
Okay.
waiting for you to join.
Okay. Okay.
Dr. Navneet, we can log out. We can continue the discussion in the
Okay.
meantime.
Okay.
Dr.
Okay.
Kanika, please.
So till ma'am is joining, Dr. Navneet is joining. Today's session will be corneal optics and optic principles. Right? So we will be talking about optical properties of eye, basic laws of optics, some optical properties of the eye, and certain aberrations which are there as flaws in these optical properties, which manifest themselves as aberrations. So Dr. Navneet will be holding today's class. She will be, I think, logging in few minutes. So this class, I have gone through her presentation. It will be a very nice and lucid presentation. So what happens is the optical properties of the eye, they have certain flaws which manifest themselves as aberrations. And these aberrations are depicted in a Zernike polynomial, right? So these are presented in Zernike polynomials in which first two rows, n1 and n2, they are lower order aberrations, while higher rows, n3 onwards, are higher order aberrations. Most common aberrations which are there in eye are spherical aberrations, trefoil, comma. So these are the aberrations which come, and certain clinical applications of these aberrations, the optical properties of the eye, optical principles, is also what will be touched in the last.
Thank you, sir. I think I would like to take this opportunity to reintroduce our chairperson and speaker because there was some
Yes.
network glitch at my end also. So, Lakshya sir, I've already welcomed you. Dr. Uma ma'am, sorry we were having some technical glitches. We welcome you to today's session, ma'am, and giving your vast experience of cornea and your diagnostic skills and clinical skills. I'm sure you will have some many pearls for us regarding the topic. And for the DNB students also, let me also tell everyone that Dr. Uma ma'am is herself mentored as many as 17 to 18 theses, and ma'am is a DNB coordinator and a nodal officer, and she's in charge of post graduation education. Ma'am has done more than 7,000 FACOs, more than 2,000 ECCs, and 1,000 PKs, apart from other corneal procedures like DSEC, DALC, FALC, PTK, and PRK. Ma'am has contributed to more than 15 chapters and authors of various books, and herself, ma'am has authored a book called Cornea Illustrated. It is a beautiful book. We've all gone through it. It has all illustrated pictures of various diseases and based on ma'am's own clinical practice. She has multiple awards and achievements to her name. I think if I start enumerating all her accolades, we would finish today's session. Ma'am has like numerous accolades to her name. She's highly accomplished surgeon and a very well read and accomplished academician as well. Welcome, ma'am, to today's session, and it's our honor to have you here.
Thank you so much, Kanika. I think I'm overwhelmed by your introduction. Thank you.
Dr. Navneet is our young and dynamic consultant at CFS. She's an associate consultant. She also has been a very meritorious student throughout her career, and she has won multiple gold medals. Um, Dr. Navneet will be taking us through today's session. I hope she'll be joining in some time.
Dr. Navneet, ma'am. Dr. Navneet ma'am.
Dr. Navneet, are you facing some difficulties?
Oh, she's just joining in 1 minute, ma'am.
Kanika.
Yes, sir. Yes, sir.
Uh, so we can talk something about till Dr. Navneet is joining in.
Uh, I think so. Just give me a minute. I think ma'am has sent the mail to me. I'll try to present from my screen.
Okay, that is better. Okay, okay. It's visible, visible.
You can take over. I will be shifting the slides for you.
Okay, please start, ma'am.
Hello, thank you so much, and sorry for the delay. So we will be discussing on corneal optics and optical principles today. It's a very important topic since it includes the basics of any refractive surgery. So starting with what is light? So light is a visible portion of the electromagnetic radiation spectrum, and it lies between the ultraviolet and infrared portions with wavelengths ranging from 400 nanometers at the violet end to 700 nanometers at the red end. So this wavelength, it's a broad wavelength which comprises of various different light waves. So can we shift to the next slide, please? So light has various properties. It has rectilinear propagation of light, which means that light travels in a straight line through the same media. There can be reflection of light and refraction of light. So, coming on to what is reflection of light. So, as we all know that reflection of light is a change in path of light rays without any change in the medium. So, there are incident rays, which are the incoming rays. When they strike a surface, they're reflected into a different direction. So, reflection can be specular reflection or a diffuse reflection. Specular reflection happens when the light rays they strike a smooth surface. Now, what is refraction of light? So, refraction of light is a change in path of the light when it goes from one medium to another. As we can see in this animation, the light rays, when they strike at the junction of two different media, the light rays they bend as according to the refractive index of the light rays. So, important are the laws of refraction. Now, why we need to understand these laws? Because that is how the light traverses through the cornea as well. So, there are two important laws of refraction. The first law states that the incident and the refracted rays are on the opposite sides of the normal. So, a normal is a perpendicular line at the junction of the two media, and the incident ray, the refracted ray, and the normal, all of them are in the same plane. The second law of refraction states that the ratio of sine of angle of incidence and the sine of angle of refraction is constant for a pair of media. So the refractive index given, provided that it is the same, the sine of angles of both incident and the refracted rays should be normal and is constant. So this is called as the Snell's law of refraction. This was one of the main important laws of refraction. Now coming to the eyes. Now if we look at the eyes as a camera, we have various different adnexa and organs, subparts in the eye, which acts as the different parts of a camera. So you can assume the eyelids to be the shutter of a camera, the cornea, which is the focusing system, in the lens, which is also a part of the focusing system, then iris, which acts as a diaphragm of the camera, the choroid, which is a dark chamber in the camera, and the retina, which is the focusing light sensitive film. So the optical system in the eye comprises, which is the focusing system of the eye, comprises of the tear film, the cornea, the aqueous humor, the lens, crystalline lens, and the vitreous humor. So as a whole, the total these provide a total dioptric power to the eye of around plus 58 diopters. However, this power is also divided into the corneal power and the lens power. So cornea contributes to around 43 diopters and the lens contributes to around plus 15 diopters. So coming on to the most important structure for which we have this class today, the cornea. It's a transparent avascular tissue which comprises of the outer fibrous coat of the eyeball and forms 1/6 part of the outer layers of the cornea. So cornea has 6 layers with varying composition and densities. From outside to inside, we have the epithelium, the Bowman's membrane, stroma, Duar's layer, Descemet's membrane, and the endothelium, as can be shown in this diagram. So, as we discussed, that the cornea provides a plus power of plus 43 diopters with a refractive index of 1.376. Now, the cornea also has two surfaces, anterior surface and the posterior surface. So, anterior surface of the cornea can be compared to a plus lens. So, it's a convex surface which provides a power of plus 48.83 diopters, and the posterior surface can be compared to a concave surface which contributes to a power of minus 5.8 diopters. So in total they provide the cornea of plus 43 diopters power. Now, the cornea also varies in dimension and in the anterior and the posterior surface. So the anterior surface is slightly elliptical in size. The vertical dimensions are smaller as compared to the horizontal dimensions. This is because of overhanging sclera superiorly and inferiorly. So the sclera compresses the cornea in the superior and the inferior aspect, hence shortening it in the vertical dimensions. Also, the corneal thickness varies from center to periphery. So, in the center, on an average, a cornea is 520 microns, and it becomes thickened to around 800 microns at the periphery and is thickest at the limbus with a thickness of around 1200 microns. Also, because of this, there's a change in radius of curvature also of the anterior and the posterior surfaces. The anterior surface has a radius of curvature of around 7.8 millimeters, whereas the posterior surface has a radius of curvature of around 6.7 millimeters. So this aspherical shape of the cornea's anterior surface causes a baseline astigmatism of around 0.25 to zero point 0.5 diopters normally. It is normal in all the cases. So changing corneal surface's radius of curvature with distance from the center of pupil to the pupillary margin in itself causes few spherical aberrations of around 0.21 to 1.62 diopters. So these changes lead to with the rule astigmatism, which is present normally in all the eyes because the cornea is a aspheric lens. So we can assume that below the age of 50 years, since the vertical meridian is steeper, the astigmatism is birule with the rule. And with increasing age, the horizontal meridian also becomes steeper and eventually it becomes against the rule astigmatism. So now we are discussing the optics of the cornea. We will be starting with the optics of the whole eye first. Now the eye is divided into various different axes. We have the optical axis, the visual axis, and the fixation axis. So as you can see, the optical axis is a imaginary line which traverses through the center of the pupil, through the nodal point, which is the center of the lens, through the center of rotation of the eye, and eventually onto the retina. So this green line represents the optical axis, which is a straight line coming from a far off object. So next is a visual axis. So visual axis is a imaginary line which traverses through a point of object of concern, point O, and traverses through the nodal point of the lens and onto the fovea. So the visual axis is different from the optical axis. And third is the fixation axis. So fixation axis is the imaginary line which passes from the object of concern, which is at a near point, to the center of rotation of the eye. So why these three are important is because these three axes form a few angles in the eye. So those angles are of importance. So next slide, please. So first is the angle alpha. So as you can see in this previous diagram, angle alpha is the one which is formed between the object of concern at near, the nodal point of the lens, and the far point. So this ONA forms the angle alpha. So second is the angle gamma. Angle gamma is the angle which is formed between the lines joined by the object of concern, the center of rotation of the eye, and the far object. And the third is, which is of the most importance in refractive surgeries, is also angle kappa. Angle kappa is the angle formed by the object of concern, the center of the pupil, and the far distance. So why angle kappa is important? Angle kappa normally varies between 4 to 6 degrees, and it is not situated in the center of the pupil. So this angle kappa is as seen, it's larger in exotropias, larger in the left as compared to the right eye, because in majority of the population, the right eye is the dominant one. So there's a positive correlation between angle kappa and hyperopia. In people who have a hyperopic power, who have a hyperopic refractive error, angle kappa is seen to be slightly on the positive side, on the higher side. So knowing the angle kappa is essential in centration in refractive surgeries and in cases where multifocal eye implantation is planned. So next we'll be discussing about the schematic eye. So schematic eye was basically an optical representation of the various different important points in the eye. This was first given by Gullstrand. So he defined various points in the eye. He defined two principal foci, two principal points, and two nodal points as per the physiology of the incoming light rays. But because so many points were involved and so many optical points were defined by Gullstrand, understanding of this eye was slightly on the difficult side. So smaller but a revised definition of this optical points was given by Listing and Donder. They gave two separate models, which was called as a reduced eye. This was to simplify the optical system of the eye. So and they basically converted the 2 points into single points. So there was one principal point and one single nodal point lying midway between two previously existing principal points and two nodal points respectively. So comparing both the models by Listing and Donders, basically the principal point, nodal point, anterior focal point, posterior focal point. These were four major points of concern to understand the optical system of the eye, and they were situated 1.5 millimeter behind the anterior corneal surface, the principal point, whereas Donder simplified the mathematical numbers. He just removed the decimal points and gave whole numbers for all this. So comparing both these, they simplified the optical system of the eye. Next slide, please. So understanding the corneal optics. So cornea is the most powerful refractive element of the eye, giving a power of plus 43 diopters. And shape of the cornea is important determinant of refractive power of whole of the eye eventually. So, how the refraction occurs through the cornea? So, the cornea anterior surface is, as I suggested, is convex anteriorly. It causes convergence of light rays. So, this convergence has a major role in ocular refraction due to difference in refractive indices of air, which is 1, and cornea 1.376. Now, due to this difference, the light rays they bend inwards. So, although cornea is composed of multiple layers, they all work as a single refractile unit. So, next slide, please. So, why light transmission through cornea is not affected despite being despite being composed of multiple layers? This is because each corneal collagen fibril is an ineffective scatterer of light, and each keratocyte nucleus, although mildly scatters some light, but the cell body is an ineffective scatterer of light because it is transparent. The cell body is composed of transparent intracellular cytoplasmic water soluble corneal crystallins. So eventually there is no scattering of light through a keratocyte. Keratocytes are also evenly distributed in the corneal stroma in a lamellar clockwise circular arrangement. This also inhibits scattering of light rays. And the fourth point is that the cornea is a thin structure. It is not thick enough to cause scattering of light. So, if an increased refractive index imbalance occurs within the fibrils, keratocytes, or the extracellular fibrillar matrix, which is present in the cornea, light scattering will increase tremendously in the corneal stroma, which will result in loss of transparency and will also reduce the light traveling through the cornea. So, this is usually seen in scenarios with corneal edema, scars, dystrophies, and degenerations. So now we'll also define various optical zones of the cornea, since all the different zones, they scatter light differently. So first is the central optical zone, which is of around 4 millimeters in diameter. It is also called as the apical zone, the corneal cap, or the central spherical zone. It is a symmetrical zone, and refraction in this zone differs by less than 0.25 diopters. And since in this 4 millimeter zone, the radius of curvature does not vary by more than 1 diopters or 0.05 millimeters, so the light rays, they invariably travel in a straight line through this zone. Second is the paracentral zone. It is around 4 to 8 millimeters in diameter, and it is flatter as compared to the other peripheral zones. Third is the peripheral zone, which is around 8 to 11 millimeters in diameter. Again, the cornea is relatively flat in this zone, and it is the most aspheric zone, which means that the light rays will invariably fall on a single point on the retina. And the last is the limbal zone, which is a 0.5 millimeter wide strip in the limbal area, which abuts the sclera. There is minimal light passage through that area. So within the three central optical zones, there are three major corneal reference points as well. which are extremely useful in determining the shape, refractive power, and biomechanical properties of the cornea, since they are statically fixed reference points. So these 3 points are the corneal apex, the corneal sighting center, and the thinnest corneal point. Now, defining the corneal geometry. So first of all, we'll define the corneal apex. So corneal apex is the steepest point of the cornea. As you can see in this diagram, it is measured usually using a keratographer or a topographer. The corneal intercept of the imaging device's optical axis is termed as the device axis point. So why we need to understand the corneal apex is because knowing the corneal apex is important in selection and fitting of contact lenses, and also to determine the geometric aspheric shape of the cornea. Second was a corneal sighting center. So corneal sighting center is the principal axis joining a distant fixation point to the fovea. So as you can see, that line of sight is the point which is passing to the center of the pupil, whereas corneal sighting center is a point, is an axis which is passing from the fixation object to the center of rotation of the eye. So on an average, it is around 0.4 millimeters nasal and 0.3 millimeters superiorly to the undilated pupillary axis. So why CSC is important? Because it is required to understand that we need to achieve best results with our refractive surgeries, particularly with retreatments and customized ablations, and also for calculating the IOL power, especially in patients who have undergone previously refractive surgery or with higher order aberrations. And next is the thinnest corneal point. So by definition, it is the thinnest point of the cornea. So thinnest corneal point allows clinical differentiation of corneas with the normal biomechanical properties from those with current or previous keratosis. So as you can see in this map, the corneal thickness is usually denoted by a clear circle in this quad map. And now coming to planes and meridia of the cornea. So we have a meridional plane or a tangential plane, which passes through the center of the cornea, a corneal meridian, which is around 0 to 180 degrees, and it is the intersection of the meridional planes. Hemimeridia or semimeridia is a meridian which passes from the center outwards, and sagittal plane is perpendicular to the meridional plane through a point and contains the surface normal, as you can understand in this diagram. So the central is the normal. So next slide, please. Now, understanding various different terminologies, these will be helpful to understand the various diagnostic procedures which are required before the patient undergoes any refractive surgery. So one one important reading is the mean K reading. So it is an arithmetic average of the central sim Ks on the anterior corneal surface. And normal mean K is less than 47.2 diopters, usually in normal patients. So as you can see on this quad map, on the refractive map, the mean K is denoted by this red circle. So then there is a maximum K reading. So K max on the anterior corneal surface is measured by the anterior sagittal curvature map. As you can see on this Bellin, Ambrosio, and Ernst ectasia display, there is a separate display which shows the K max reading, as is again denoted by this red circle. Axial distance. So axial distance, supposedly this is the surface of the cornea denoted by the green line. And there is a fixed point S on the surface of the cornea. So the light rays which are entering through that point S onto a point A, which is the reference axis along the normal of the cornea. This is known as the axial distance. So this is usually important for refractive power maps, since the image formed at this point, when the light rays cross through this point, will be measured onto the refractive power maps. Next is the surface height. So surface height means the actual elevation of the corneal surface relative to a reference. So a reference can be a plane tangent to the apex or a best fit reference fair. So topography display of surface height relative to a reference sphere provides clinically useful information and creation of color-coded maps. So again, as you can see, the point S from the normal, which is drawn along the apex or the best fit sphere, is the surface height. So any object on topography maps varying according to this point will be defined by various colors. which you will eventually get to know in the upcoming classes. So then next is a reference axis. So reference axis defines the center of topographic display and thus the meridional planes in which axial shape and curvature are determined. So basically this axis is the one which is passing through the center of rotation of the eye. Again, these will be important in understanding the various topography methods later on in the upcoming classes. Now coming on to the usage of these optics and their terminologies in the optical principles. So, most techniques employed to study the shape of the corneal surface are based on the fact that the anterior corneal surface, by a rule, is a convex mirror. So, size of the image varies with the curvature of the cornea. Greater the curvature of the cornea, smaller will be the image size. Now, first of all, we need to understand what are catoptric images. These are also called as Purkinje-Sanson images. These are formed inside the eye as a result of reflection from each refracting interface of the eye, which is the anterior surface of the cornea, posterior surface of the cornea, anterior surface of the lens, and posterior surface of the lens. So we need to understand that the anterior and posterior surface of cornea and the anterior surface of lens, these are convex surfaces. So eventually they form erect and virtual images, whereas the posterior surface of the lens acts as a concave surface and will form a real and inverted image, and so it is not visible in this image shown on the left. Next slide, please. Now, understanding keratometry. So, keratometry was first devised by Helmholtz. It measures the radius of curvature of the anterior corneal surface from 4 different reflected points, which are about 3 millimeters apart. So, one disadvantage is that keratometry scan is only limited to these 4 points. So, the first Purkinje image formed by the anterior surface of the cornea is measured using a keratometer, and hence the radius of curvature is determined. So as you can see in this ray diagram, a distant object, light rays coming from a distant object, they strike onto the surface of the cornea and they form a virtual, minimized and erect image. So this image, the size of this image is measured and hence the radius of curvature is determined by the machine using a software. Second was keratoscopy. So keratoscopy refers to the evaluation of topographic abnormalities by direct observation of mires which are reflected from the cornea. So there are 3 different types of keratoscopes: a Placido disc keratoscope, photokeratoscope, and a video keratoscope. So what is a Placido disc keratoscope? It was initially developed in 1880 by Antonio. This consists of equally spaced alternating black and white rings with a hole in the center. That hole in the center is for the observer to look at the patient's cornea. And distortion in these rings will point towards the distorted corneal shape. So in the direction that the rings are distorted will determine whether the cornea is steep or flat in that direction. So disadvantages of a Placido disc are that small abnormalities cannot be picked up, cannot be used in epithelial defects or ulcers, and cannot be used in corneal scars since the surfaces won't reflect the rings. Then there was a photokeratoscope. So it consists of a photographic film camera attached to a keratoscope. The keratoscopic image is photographed and the size of the images are analyzed using a software. So in this, the corneal curvature is measured by distance of the keratoscopic rings from the cornea, magnification of the virtual image by the anterior corneal surface, and the focal length of the objective lens of the camera. So again, photokeratoscope, although was quite commonly used, but again it has disadvantages because the closer the it does not really project the photograph clearly onto the film. In this, again, we look at the how close the lines are projected. So the closer the lines, the steeper will be the cornea. It usually covers the paracentral area, overlapping into the central and the peripheral zones, but it leaves the optically important central 2 to 3 millimeters. So again, we cannot determine the corneal steepness in the center. And current photokeratoscopes have around 9 to 15 rings, which cover around 55 to 75% of the corneal surface. The most commonly used nowadays is this video keratography, also known as VKG. It consists of a television camera attached to a keratoscope. Video recording of the corneal imaging is done in this case, and so the videos are analyzed by a pre-built software inside the machine. So this covers approximately 95% of the corneal surface and covers around 8,000 to 10,000 points across the corneal surface. It consists of a projection device, a video camera, and a computer. Next slide. Now, the latest technology is a raster stereography. So it projects a direct image on the cornea. It projects a calibrated grid consisting of horizontal and vertical lines which are spaced 0.2 millimeters apart onto a fluorescein stained tear film. So a computer algorithm analyzes the images and hence the shape of the cornea is determined. So it gives an accuracy of around 0.3 diopters for a diameter of 7 millimeters. So advantages is that it covers whole of the cornea and also includes part of the sclera, and there is no interference due to epithelial or stromal defects. Now these are the various different corneal topography and tomography systems which are quite commonly used, out of which high accuracy is given by the slit scanning, sheen plug imaging, high-speed ASOCT, and very high-frequency ultrasound. All of these will be covered in the upcoming lectures in detail. Now, also one important aspect of corneal optics is corneal aberrations. Now, aberrations are small optical irregularities in the cornea and the crystalline lens, which impact the quality of the retinal image. But since most of the light rays are transmitted via the cornea and undergo the most change in their path, so corneal aberrations do carry importance in planning and planning the surgeries, including refractive corrections. So aberrations can be lower order or higher order. So cornea accounts for approximately 90% of ocular aberrations. Measurement of wavefront aberrations and incorporation of this data into treatment profiles has led to a significant improvement in the quality of vision following refractive surgeries, since all of these can be corrected accordingly. So, corneal aberrations and the ability to measure them has improved the ability to correct surgically induced higher order aberrations also, in addition to the lower order aberrations. And it is also helpful in the early detection of pathological conditions such as keratoconus. Corneal aberrometry, it has the ability to evaluate the anterior corneal surface, which is the most effective refractive surface of the optical system. And it can also assess the posterior ocular surface in the newer technologies. So the Scheimpflug placido tomographer, it provides anterior and posterior corneal topography, corneal wavefront analysis, as well as the corneal pachymetry. So this is quite important in assessing any patient before undergoing refractive surgery. Now, what is corneal wavefront? It can be calculated from the corneal topographic height data using an algorithm. So, an algorithm is a calculation which is usually done by reconstructing the corneal geometry after the machine has calculated the various points on the anterior and the posterior surface relative to the reference axis, which we discussed in the previous slides. So RMS values of total higher order aberrations, trefoils and commas, are highest in astigmatic eyes and lowest in emetropic eyes. Now, why this is important? Because higher order aberrations, when they're higher in patients who have high astigmatism, so the final outcome after refractive surgery will differ accordingly. It's better that we assess these higher order aberrations and correct them accordingly for a beneficial outcome. Now, spherical aberrations are also very less in patients who have astigmatism. And so higher order aberrations should be evaluated in refractive surgeries. Now, in adolescents with mild to moderate myopia, the posterior corneal surface shame may play a compensatory role in the balance of corneal aberrations. Hence, it is essential to also understand the posterior corneal surface and the aberrations associated with it. Corneal coma may also play a compensatory role in posterior corneal surface astigmatism, which was valuable for the treatment for improving visual quality. So, clinical uses of aberrometry, wavefront guided refractive surgery, early diagnosis of keratoconus, and wavefront guided LASIK enhancement. So, my take home message from this class would be for the students to understand that cornea is the most important component of the optical system of the eye. The corneal shape is an important determinant of refractive power of the whole eye. Hence, it is very important to determine the corneal optics before planning any refractive surgery. Understanding of corneal optics is essential in diagnosis and management of refractive conditions which may be pre-existing before a patient undergoes any surgery like any ectasias or any other pathology. And topography and aberrometry are essentially, they work on the principle of images refracted from the corneal surface. So it is very essential to understand the corneal optics as a whole before understanding the concept of any refractive surgery. So thank you everyone for your patience listening.
Thank you, ma'am. I congratulate you for a nice presentation. Very
Thank you.
nicely done, ma'am. Yes. So you elaborated on the optical principles on corneal optics, and finally, the irregularities in the corneal optics manifest themselves as aberrations. Yes. So I would like to elaborate a little more on these aberrations.
Yes, sir.
Spherical aberrations, higher order aberrations, most common are spherical aberrations, trefoil, and coma. Spherical aberrations are because the central rays passing through any optical system, they bend less, while the peripheral rays, they bend more, right? So
Yes, sir.
peripheral rays, they bend more and focus slightly anteriorly, while the central rays, they bend less. So this causes two foci of convergence, and some amount of spherical aberrations are beneficial because they give us some depth of focus. Without using your accommodation, we can focus at objects at different distance, taking help of this spherical aberrations. But our optical system is such that it keeps the aberration, it tries to keep the aberrations in tolerable range. So how corneal aberrations are negated is, number one, when I told you that peripheral part of the cornea or peripheral part of any optical system, it bends the rays more, but our peripheral cornea is flatter. Our peripheral part of the lens is less dense, less refractive index, because it has more of cortex and less of nucleus. Peripheral rays are stopped by the iris, and peripheral retina has low resolution, right? So these keeps all the aberrations under check. Coma is when you see a point focus smeared and see a tail of a comet. And trefoil is when you see a point focus smeared like a Mercedes-Benz sign. And all these are also because the central part of the cornea is not the central part of pupil, is not the central part of the lens. They are not in straight line. That's why these coma aberrations are there. And these are also taken care of by retina when they are, when we say that cones are more receptive to central rays rather than oblique rays. So all these things keep these aberrations in check, and you have rightly pointed out, we check these higher order aberrations before planning for nowadays for cataract also and refractive surgeries. And if these higher order aberrations are on higher side, we go for wavefront optimized or corneal topography guided LASIKs, or in IOL surgeries, avoid multifocal IOLs or use aspheric monofocal IOLs if higher order aberrations are high. So thank you so much, Navneet ma'am. I would request Uma ma'am to share her thoughts on the lecture.
Very well and beautifully covered, Navneet. It's not
Thank
a
you.
simple topic as it appears. It is quite difficult to explain difficult things in a simple manner, which you have done.
Thank you,
And I think it covers it beautifully. And Dr. Lakshay has also covered nicely the aberrations. As a corneal person, I would only like to say that yes, cornea is such a beautiful structure, but even a slightest of opacity on the cornea can, and the light nebular opacities can cause so much of refractive issues. You just look at the patient and say, oh, a few SPKs, and why is the vision so less? So, and how much the refraction changes once the SPK is resolved, the patient is so much better, whatever the reason for SPK. And the other thing, one we should remember that one should not always look at a topographic map and say, oh, this is ectasia. One should look clinically. It could just be a scar. It could just be a thinning because of the scar. And it's not an ectasia per se. So it's always a clinical correlation. One doesn't make a judgment based on the topographic maps. Everything is a clinical correlation. And the other thing is the tear film. The tear film makes so much of a difference to the optical surface. If the patient, like you put a drop of lubricant and then you do the topography, or if the patient has a dry spot, you're making the patient sit in an AC environment, each time your topography is going to vary. And that is going to reflect on your surgery, on your IOL power calculation, and so much of it. So I think one should take very careful clinical evaluation of that. And the other point, which is very important, is your angle kappa, alpha, and especially in the case of multifocal IOLs. Many times you burn your fingers by giving that. We don't measure routinely in every case. But then you find a most unhappy patient where it is not properly, it may be properly centered, but it has a large angle alpha. And then you are like, I mean, what have you done? You don't do eye trace for everything. So all these things are extremely important in planning, whether multifocal, whether refractive surgery, whether even doing, if you want to smoothen the surface of the cornea before you do cataract surgery, when you take out a pterygium, how much that is going to have an effect on your IOL power calculation. Do you do pterygium with cataract together, or you do one after the other? So even that affects on the surface, not only in case of the refraction of the cornea itself, it varies. When you remove the pterygium, then the amount it presses on the cornea, with the rule astigmatism would change, and your IOL power would change. So, the cornea is such an important surface of the eye. Like we keep telling our retina specialists, retina attached, no change. So it's attached retina probably is the, if they think is the most important thing, but the macula is important. An attached retina is of no use if the macula is not functioning. Similarly, if the cornea, a scarred cornea, you can, if it is not a full thickness scar, then of course you can do an anterior refractive, anterior lamellar surgery, or a full thickness, you have to do a full thickness corneal transplant. But what you have explained in terms of the reduced eye and Donder's eye and everything, it's like going back to our student days, and it's beautifully explained. It's not excess material on the slide. It is very nicely done. So congratulations, and it is a pleasure to be part of this. And I have learned a lot by sitting through this. Thank you.
Okay, ma'am. Thank you for the opportunity.
Thank you, ma'am.
Thank you, sir.
I would
Thank
like
you.
to ask one question. So we have a question here. What is the usual sequence of performing topography if a patient comes to our clinic? So I think what they're trying to ask here is that when should you perform topography in the sequence of events that happen when a patient turns up to the clinic? Should we do it before or any other investigations, or after?
So basically, when a patient comes to us after all the examination and everything, after the refraction is done, ideally topography should be done first before any contact procedure is done onto the eye, because any contact procedure, be it an ultrasound, be it a scan using a probe, might alter slightly the corneal shape and the corneal dynamics. So topography should be the first investigation, which should be done in a patient who's coming to our clinic planning for a refractive surgery.
Thank you, ma'am. Dr. Lakshya sir, I would have one more question for you. Now that you have your own practice, sir, how frequently do you subject your patients to aberrometry and wavefront analysis when you're planning your multifocals, or even for the refractive surgery part? Is it a regular practice?
Before refractive surgery, it's a regular practice. Before cataract, if somebody is opting for premium IOLs, I go for aberrometry. Otherwise, for normal monofocal IOLs, I don't do it.
Uma ma'am, like you mentioned about eye trace, how is your experience in your clinics with eye trace? I mean, how regularly do you think a patient comes out dissatisfied after surgery and then you have to find out what the aberrations were? And we're talking about cataract surgery here, not just the refractive surgery part.
Well, Kanika, eye trace we have used for several purposes. Unfortunately, we have not used it to its full capacity. We have done a lot of dysfunctional lens index of the patient, maybe just early presbyopic, or in a scale of 0 to 10, the patient is very unhappy and thinks, it's because of the lens. And many times you find the cataract clinically may not be much, but on dysfunctional lens index may be a very low value, then you plan cataract surgery. Having said that, it's not a done thing. People have said that even after LASIK, such a patient has improved. So my experience was dysfunctional lens index, if it's low and I've done cataract, they're okay, but they are happy. Now, the other thing in eye trace, like you find that you have done a toric IOL and then you see the rotation you can make out with the eye trace. You can see how many degrees of rotation actually, if it's not, it has rotated post-op and the vision, you are getting a cylinder post-operatively, you can detect that. Then again, in aberrations, as you say, in multifocal IOLs, especially like the trifocals, you find that you can, you can make out the aberrations, but it's not a one-to-one ratio that the HOMS or the coma or something is high and so the patient is unhappy. So you can just make out grossly that yes, the higher order aberrations and the spherical aberrations, what is the thing, but you can't say 1:1 that this is high and so this is thing. So we are really learning from eye trace more and more. I think we have to somehow it has become more like a research tool. You feel a little hesitant to charge a patient for a eye trace. So, but I think we can use it more and more. And you have to do every instrument, I feel personally, not possible in a busy clinic. Even your topography, it is said that the same topography, the same technician, the same machine has to be repeated every time. So, like when you're following up a keratoconus patient or you're following your refractive surgery patients, ideally it should be the same machine, the same technician. It can't be apples versus oranges. You have done one TMS one place, then you're following up with a shine plug in another place, then you're following up with something else. And all the values, unfortunately, the companies they don't keep the same values across the machines. So you're trying to understand what exactly the parameters are. Is the ectasia increasing? What kind of changes are happening in the cornea? So I think one is learning more and more, and more as more noise comes. Like there is so many values that come in every machine. There are a few values which are important. There are a few you can ignore. But I think it's very difficult to read a map when there are so many values. You just wonder which ones to say if there is a progression in an ectasia, which values to take. Is it only Kmax? Is it something else? Are you looking at Artmax? Is it, is it the other values like anterior float and posterior float? What are you looking at? So with every machine, you may say that, yes, ectasia is progressing. You may reject a refractive surgery candidate, but somebody else will say, no, according to our parameters, it's all right. So it is very difficult. And post any procedure, whether refractive surgery or lamellar surgery or anything, I don't know which machines you can actually give more accurate values. So even post C3R, can you rely on a shine plug to tell you that the cornea is getting thinner or thicker? And OpScan, of course, does not take, because it has an anterior and a posterior point, it doesn't know where to take it from. So the values are falsely low after a procedure. So OpScan is no longer very commonly used once you have got the shine plug and the other ones which check the posterior surface properly. So I don't know if I've gone round and round, but anyway, yeah.
Dr. Navneet, one last question for you. You mentioned about angle kappa. Could you please elaborate for our students, like in their clinics, how do they suspect a large angle kappa, or how do they measure it with the simpler techniques if they don't have an access to the higher end machines?
So angle kappa is basically, again, explaining the axis which forms joins the optical object, the center of the pupil, and the far distance. So this angle is known as the angle kappa. So in a patient who's coming to you, so you can suspect it in patients who have a higher number, a higher refractive error, or who have exotropias. So easier in a clinic setup, I think you can examine it using a simple torch light. a torchlight can be shown onto the cornea, and you can look at the first Purkinje image formed by the pupil, which is known as the pupillary light reflex. So if it falls onto the center of the cornea, and then you can ask the patient to look at a far off object. So it will obviously, the pupillary reflex will move slightly outwards. So that can be measured as the angle kappa, the distance from the center to that light reflex.
Thank you, ma'am. That's a very important clinical point that you told. And most of the students get very flabbergasted just by the words like angle alpha, kappa, and this basic terminology also scares them. So this is a very good clinical point that you've told. We have one more question on the YouTube channel, ma'am. How reliable is topography using TOMI in doing a toric lens power calculation? I think I can open this question up for Uma ma'am and Lakshya sir as well. The question says, how reliable is topography using a TOMI in doing a toric lens power calculation?
Lakshya, like to take it?
No, I would pass it to Uma ma'am.
Well,
We are now commenting on the brand of the device, that is the topographer, and whether it is reliable enough.
So I think it's like a brand wise, it's we can't say whether it's reliable or not, but topographer as a whole will be more beneficial in assessing the toricity and the abrasions as compared to calculating a toric power. I believe,
true.
as compared to is like the machines which are actually meant to measure the IOL powers.
I think nowadays we're relying more on the IOL masters and the
Yeah.
OCT based, the OCT guided instruments, you know. So it's not really, you're not depending on the topographer to tell you the torical, the axis and other things. So I don't think we are using that. Of course, you can do a topography and see that, no, you don't do just a keratometry. When you find a lot of cylindrical number or you're suspecting something, you can do a topography to give you a keratometric values to calculate. But now the IOL master is there. So, you know, these are much more accurate these days. Because you're putting a premium IOL, I think you would invest in a premium calculator also, right? And nowadays the standard has become like, patient expects nothing but the best. And so you wouldn't really, of course, you would not depend on your keratometer. You can do your topography to understand how much of the exact K1 and K2 are. But yeah.
Lakshya sir, any experience using topography in your lens power calculations?
No, we generally don't use topography. We use the normal keratometers. If it is maybe if it is post LASIK or post refractive surgeries, then you can use. Otherwise, normal patients, we don't use topographers.
Yeah, if you're post RK, post LASIK,
yes,
and
yes, ma'am.
keratoconus patients, you would like them to do that.
So these are the questions from the YouTube channel. I think there are no more questions there. Thank you so much, Dr. Navneet, for an elaborate presentation. Thank you so much, Uma ma'am, for your insights, and Dr. Lakshya sir for such a great insight at the end and the gist of the whole class. We can call it a day, sir, as you say.
Thank you, everyone. Thank you so
Thank
much.
you. Thank
Good
you.
night. Good night.